If you were stranded on a desert island, what surgical tool would you want to make sure you have with you?
Well, if I'm with you, I'd want a scalpel to be able to make sure I have enough meat to survive.
Got it, fair enough.
If I'm by myself, a tourniquet, so if I get hurt, I'll be able to not die.
There you go. Nice. Welcome back, everybody, to BIOS KOL Sessions. Today I have a special privilege to introduce Dr. Alan Hirahara. Thank you for being here.
Thanks for having me.
Not only is he one of my mentors, but I think he's one of the OGs in terms of orthobiologic use. He's the one who really advanced me in the orthobiologic field, so obviously very grateful for that. And today we're going to get some different opinions, I think, and a lot of experience on how to use orthobiologics in surgery, specifically shoulder surgery, which is what Dr. Hirahara specializes on, and how that differs from in-office use, and really just a lot of pearls from his experience. So thank you for being here again.
Thank you so much.
Tell me a little bit about your background. How did you get involved, and why were you one of the early adopters in biologics?
The thing is, it's really incidental. I mean, I'm an orthopedic surgeon specialized in shoulder and knee arthroscopy, sports medicine. Around 2007, I actually encountered one of the reps from one of the other companies that talked about PRP, and I'm like, what is that? And as I started the discussion talking about what PRP was and what the concept was, and at that point it was very early in orthopedic use, I started realizing that one of the places it could be potentially useful is in slap repairs. And that's kind of how I got started, because one of the big problems that we were seeing is that we would have failures. And it wasn't necessarily technical or anchor related, it was biological. Because the problem is a shoulder joint is devoid of blood. And because of that, and the fact that you have such a small piece of cartilage that has poor blood supply being attached to a small piece of bone which has a small area of blood options, there's got to be something to help it. And so taking the body's own resources and trying to apply them to enhance our chances that we'll heal was really the main reason I got started on all this. So from there, it just kind of blew up, but I had to figure things out kind of on my own.
Sure.
Because there was no research. There was really nothing in the orthopedic world short of a couple total knee joint studies, but not much else.
Got it. And how has it evolved over time? Obviously, you were there from the very beginning. You've seen it kind of flow through over the past, would you say, decade, even more at this point, right?
Well, obviously it's been accelerating over the past decade, I would say, absolutely right. Initially, honestly, there was so much skepticism, and I literally had someone ask me, how does it feel being out there on a limb by yourself? I mean, literally, they said that to me. It was ridiculous. The irony is that it was hard for me to understand how doctors couldn't understand that this was science-based. It's basic science. I mean, honestly, when I first started studying about PRP, I picked up an old hematology book from 20 years prior. So this is all information and knowledge that's been there. It's not new. That's what's crazy to me, that people that think, oh, does PRP work? Well, does your body heal?
Exactly. It does your body heal. That's interesting you said. I was going to make that comment that one of the things I got from you is that you were big on understanding the basic science, right? And I think that's still probably the core on why you do the things the way you do them. It's that you don't just react to, maybe a specific paper or a specific tip. You're like, hey, I understand what white blood cells do, what platelets do, and that's what kind of leads your decision making, right?
100%. I mean, I think the biggest problem that we have is that there's still a lot we don't know. Like, we don't know every single growth factor that's there, right? We don't know every single step of the whole cellular process that goes from injury to actually healed finally, which is months later. But we know a lot about it.
Sure.
And with the use of PRP, that's what has been pushed forward, is this concept of understanding how healing occurs. How does the body heal? What are the factors involved? I think that's what's been fantastic. Because it's not just something that we're saying, okay, we're going to use to help patients. It's really deepened our understanding of the process. And I think once you have a basic core tenets of the process, it makes you better equipped to understand when a new topic comes up, a new discussion point comes up. It gives us actually somewhere to actually go from at that point.
Got it.
And say, yeah, that might work. Let's check that out.
Okay. And how have you incorporated it into your surgical workflow? And could you comment a little bit how your decision making or your flow works differently in shoulder surgery versus in the office?
Yeah, it's very different. It's not the same at all. What's interesting is I started off using it in surgery, and literally it took me a couple years to start using it in my clinic because it was really surgical based of why I was trying to do it. Yeah. And then someone asked me, well, if you do so much of this, why don't you do it in your clinic? I'm like, oh, actually that would work. And we're going to have to find the workflow to make that work. So we had to kind of come up with how we were going to do it and where it was best to be used. Because frankly, at that time, no one knew what to use it for. Yeah. And so that's kind of how we had to go backwards into the basic science to get an idea about what were the processes, how could it be used. Surgically, the whole goal was to try to enhance our chances that something would heal. Now, back then, we thought it would heal stronger, faster, better. That is not the case. Okay. This is something to help the process start reliably where you want it. It's like taking a glue and putting it between two pieces of board that you're going to nail together. Mm-hmm. So getting those to potentially stick better. But it's not going to be better because you use the glue necessarily. If you have a process, it's going to make it heal. We're just putting the processes in place where we want them to give it a better chance. However, in clinic, what we found was it's not the same process because we're not holding two boards together with nails. We're just shoving glue in there and hoping they stick together. Yeah. And so it's not the same at all because you have processes that are partial tears that are uncontained, processes of tears that are contained, inflammatory processes, different reasons you're going to do something. And so you have to have a better understanding of what it is, what you have in your hand is going to do. Got it. And then we can apply it better to about what's wrong and how to fix it.
Great. So I think that's a great point. It's like, what are you trying to accomplish, right? So let's just say you just performed a slat repair. Yeah. What are you trying to accomplish with a PRP injection at time 0?
So actually, that is the best time to do it, is at time 0. If you try to do it afterwards, and we'll talk about that later, is that at time 0, you don't want to just, for example, put the PRP on top of the tissue. Because realistically, that's not going to do anything. In fact, that's what, if you look at some of the early studies on rotator cuff repair, that's what the doctors were doing. They would do the repair and then shove the PRP on top and go, I use PRP, it doesn't work. Well, yeah, because you didn't put it where it's supposed to go. I mean, if you're trying to get two boards to stick, do you put the glue on top of the other board? No, you put it between. So we had to come up with a way to get it to stick and hold in that space that you squish together. So now the signals that tell the body to go heal at that spot will go to the proper spot. So we had to come up with this method of introducing the PRP and have it clot on location. That's why using calcium chloride, that's why using thrombin is so critical to use in surgery, because you need it to clot on location to stay where you want it, so that when you suture it together, it stays there. It stays there. And really, there's no surprise, because back in the 80s, Russ Warren, Dale Cannon, they were doing all this. They were suturing in, blood clots originally. So this is not a new concept. And they found that it worked. Well, guess what? We're just taking out the stuff that doesn't work and not needed, red cells, white cells, and just putting what we need there, the platelets and growth factors, and now we're going to get a better chance of healing than they did. But yet, they started this.
Got it. Okay. Now, do you see any role for, for instance, you've put, the glue in between the two boards, you've repaired the labrum. Do you also just inject into the joint on the way out to create, let's say, a reduced inflammatory response to the surgery? Do you double dip in that regard?
Absolutely. And that is a wonderful example of trying to understand what you're accomplishing. Okay. So all these other people say, okay, I'm going to put PRP into the joint, put PRP into the subacromial space. I'm going to help my healing. Yeah. No, you're not. Yeah. Not at all. But your point is perfect, exactly right, because obviously you understand, is that putting it in as you leave will, one, help control hemostasis. Because what do platelets do? They stop bleeding. Right. It's what do platelets also do? They diminish inflammation. So they're going to diminish inflammation. They're going to also, and it's been proven, diminish pain. There's some evidence that also can diminish antibacterial activity, meaning it could be antibacterial as well. That's some of the research has shown as well. So there's a lot you can do in a post-surgical non-repair situation.
Yeah.
So that's why even with a meniscectomy where there's no repair, I will use PRP on my way out, just like what you said. The idea is diminish pain, swelling, and inflammation. Now, will that person with a meniscectomy have the exact same outcome as someone that didn't have it 6 months later? Yes. They're going to have the same outcome because ultimately it's not going to change their recovery down the road, but they'll feel better faster. They'll have less swelling, they'll have less pain, they'll get back quicker, they can rehab quicker. So in the early phase after surgery, definitely it shows.
Got it. Okay. And in terms of that, are you pretty much trying to do PRP on almost every surgery you perform? You know, how do you work, I guess, two different scenarios, right? One is, how do you discuss it with the patient that I'm going to use PRP in your procedure, and B, you know, from an insurance perspective, you know, how do you work those two things?
Well, that's changed. Yeah. So for the first 15 years, I was doing pretty much PRP on every single person.
Okay.
Absolutely. Yeah. In the last 5 years or so, roughly, what I've been finding is that where even though the insurances weren't authorizing or paying for it, my hospitals were writing it off.
Yeah.
Because it's not a big cost, frankly, to do. So the hospitals were just writing it off, and then we were able to do it for these patients, and we were seeing amazing outcomes.
Yeah.
In the past couple of years, it's completely changed. The hospitals now are billing the patients thousands of dollars for a frankly couple $100 procedure.
Yeah.
And it's out of control.
Yeah.
I even had one hospital tell my patient they were going to charge him $23,000 for a PRP injection. Wow. Which, I'm sorry, that's ludicrous.
Yes. Yes.
And that's out of control. So obviously I can't condone that.
Yeah.
And so now I don't do PRP or stem cells unless the patient understands that the hospital, which I have no control over, might charge them.
Got it.
And so now it becomes a conversation of, do you want this? Do you want the maximum possible?
Got it.
And so now we're more discussing like, okay, what's better for you? And admittedly, when it comes to a difficult situation where someone has poor healing potential, like a meniscal repair, like some situation where they have a poor healing potential like a diabetic or a heavy smoker or obese person, or they've had known problems, that's when it's even more critical to consider these alternatives to help them have a better chance of healing.
Yeah, got it. Okay. Well, let's get into the nitty gritty. This is a discussion we've had over the years, and also we're going to have a link at the bottom to some of our previous webinars where we go head to head and have a samurai sword fight on some of these topics. But today we're going to keep it friendly?
No.
No? All right, fair enough. So what's more important to you? Platelet dose or leukocyte concentration, specifically for a surgical adjunct?
Okay. And that's a key point.
Yeah.
That's the key question, because really it is different for surgical and non-surgical. In a surgical situation, what I found through my experience and a study that we did like 15 years ago, white cell count, neutrophils specifically, is the most important factor.
Got it.
In terms of quantity of platelets or quantity of stem cells is much less important. Why is it different? The reason why it's different is because we suture stuff together, and our sutures are high tensile strength sutures. So it's like having a wire inside holding everything down. And if you can imagine, if you take a wire and put it through a tissue versus putting a wire through a leather canvas and then pulling, the tissue is going to rip apart. The leather might actually hold that wire. Well, here's the problem. White cells create a zone of weakness because of their inflammatory properties. And what happens is that if you increase the amount of white cells that are present there by doing leukocyte-rich, what will happen, and I've seen this and I have demonstrated this very clearly, is that those sutures will rip through the tissue. And it'll create a linear cut through that you can see that's clearly from the suture. And the minute you get rid of those leukocytes, that goes away and never happens.
Interesting.
So the reality is that in a surgical situation where you're suturing down tissues, leukocytes are the most important key to that surgery. You cannot concentrate them.
Okay.
You will have a severe outcome.
Got it. So you're not necessarily saying you want a low dose PRP, you're just saying you're willing to sacrifice some of the platelet dose or the MSC dose just to make sure that you do not get neutrophils.
Correct, because otherwise you will have a failure.
Got it. Yeah. Okay, and that's been how you've trained me, and I think neutrophils, it's really important to understand, right? There's not just one white blood cell.
No.
For instance, monocytes on the other side. They have potential for healing. There's obviously the change from an M1 to an M2 macrophage. But I think the problem is that in today's systems, we just don't have the way to really, you can reduce neutrophils and increase monocytes, but you can't get rid of neutrophils altogether.
You can reduce them significantly enough where it is adequate. It's a question of simply making sure you don't augment them.
Got it.
If it's a standard amount, it doesn't have a severe impact, because the thing is, when we do our surgeries and we have normal neutrophils in the area from the blood coming in, right, from the bleeding from the site, it doesn't impact. We don't see those cut-throughs.
Got it.
So therefore, it's the concentration of the leukocytes which matters. And as long as you keep them at one time or lower, you're fine.
Got it.
But you cannot start increasing that amount. So for example, you talk about systems. There is a system that, in fact, that I use that can, in fact, make sure that I can reduce the amount of neutrophils, but still be able to get some monocytes. And for example, when I use my stem cells, I do that. I have a setting which makes sure that I can get those, some stem cells. Will I get maximum? No, I won't.
Yeah.
But I'll get some, and then I'll be able to eliminate my neutrophils and still have a good outcome.
So what you're talking about is bone marrow concentrate,
Right.
Correct?
Right.
And when you're preparing it, you prepare in a way where you can maybe sacrifice some cells, but make sure that neutrophils are significantly reduced.
Correct.
Okay.
And that's what's critical, because if you don't understand that, you don't understand what your specific product of ACP or PRP or BMAC that you're using will give you, you will unknowingly potentially cause a problem.
Yeah.
And as we all know in physicians, we are supposed to do no harm.
Yeah.
Well, you're doing harm if you don't understand what you're doing.
Got it. How have you managed, the back table, right? So you come into the OR, how have you managed your team being able to draw the blood in the pre-op setting where you can focus on the surgery and your PRP is ready for you?
Yeah, that is actually a great question, because that's something that took a lot of time to kind of figure out the best methodology, because I'm a fast surgeon. Yeah. So I'm not in there a long time. So my stuff has to be ready when I need it. Yeah. Like I'll do a meniscectomy in 5 to 10 minutes. So the problem is like if it's not ready for me, we have a problem. Now I'm sitting around in the patient under anesthesia longer than I need to be. So in general, on average, the blood on average is drawn in pre-op. We do use ACDA, which is an anticoagulant, to make sure the blood does not clot. That's critical, because what it does is it removes the calcium from the blood so it will not clot. That's critical for clotting. Then what we do is when we then go to use it, we're able to spin it, manipulate it, do what we need it to do. It is still minimal manipulation. We're able to then have it prepared and ready on the back table for me. The key issue here is that then we must use every single time a double syringe system, which then goes into a mixer that comes out and then will clot on demand for me. The reason why I'll clot on demand is that in one syringe, we'll have the product of either PRP or BMAC, and in the other one, we will have a combination of calcium chloride and thrombin. And what that does is that as I use it, as it comes out, within usually about 1 to 2 seconds, it will start to clot so that I can get it to clot. And when you clot it in situ, the difference is that what happens is that those pseudopodia from the platelets will then deploy and they'll then stick together. But then they won't just stick together to each other. They'll actually stick together to your tissue. And they'll stick against your tissue, your bone, or whatever you want it, and it's not going to float away. So being used in an aqueous environment like an arthroscopy, it's totally acceptable. So you don't have to drain the joint and then have to deal with all the blood. You can keep the flow of water elevated, and it's not going to get in your way, and it won't inhibit the actual clotting mechanism of your PRP. Whereas, for example, in the clinic, when I'm doing PRP, the difference, big thing there, I don't necessarily use ACDA because I'm going to draw the blood, spin the blood, inject the blood within a 10-minute time period. So therefore, I don't have to use ACDA, therefore I don't have to use calcium chloride, I don't have to use thrombin, and I can just have it clot through the natural processes, intra-articularly, intramuscular, whatever you're going to put it. So that's the big difference, is that using it surgically, you have to understand what you're going to get out of it and how to use it properly.
Okay, so to get it more specifics, how much blood do you like to draw in the pre-op area, and let's say you're doing a slap repair or rotator cuff repair, how much volume of PRP are you going to inject into your repair?
So the volume of blood I use with the system I use, I get 60 cc's of blood, and that gives me on average between 8 to 10 cc's of PRP.
Okay.
And I'm talking about PRP, not BMAC. That's a different situation. PRP, the nice thing is that gives me plenty. Because the reality is that when you go to put it into a slap lesion, a rotator cuff repair, whatever, you need less than a cc. Because you just need enough to create a small clot in that region. It's going to squish down. And any excess will just squish out. So we just need enough in that area. Now, if you're going to use some type of a scaffolding there and you're going to use a higher volume, that's fine. But in general, it's usually not a large volume you're going to use. And so there's going to be plenty to use, as you stated earlier, as we're leaving to inject either into the joint or subacromial space or wherever I think there's going to be the most bleeding or inflammatory process.
Got it.
So there's usually plenty. BMAC is different. BMAC, the system that I use, they actually give me 2 syringes and you're supposed to draw 60. That's never enough. Because bone marrow has so much other things inside the canal, there's cells, vessels, and other things besides blood. When you go to filter it, you can't even get to 40 cc's, which is the minimum you need to process it. So I always draw 3 syringes actually, and then I can get just either 40 to 50, honestly.
Okay.
Yeah, and so that's why you have to be really careful.
Okay. And with that, are you big on aspirating the bone marrow from the site that you're going to be operating? Like if you're doing a knee, a tibia, do you do the shoulder? If you're doing shoulder, or do you like to do iliac crest? What are your thoughts on that?
So I think there's no doubt that iliac crest is the best way to do it. And I think you and I wrote that paper on the best method, the best technique.
Yes,
right?
Check out the link below.
Right.
It'll be there.
Right. So we wrote that paper about that. And yes, I actually say that is the best way. If you want to maximize the amount of bone marrow mesenchymal stem cells, there's no doubt that crest is best, 100%. However, surgically, number one, it's harder to do because you can't have the person flip back and forth. Number 2, the other issue is that it's not necessary because I don't need, the highest count of bone marrow. I'm just trying to stimulate it to be enhanced healing.
Got it.
And I know Hernigu came up with that paper saying that there was a direct correlation between the number of stem cells and the success rate of his cuff repairs, which, to be blunt, doesn't make sense because his failure rate was much higher than the average.
Interesting.
And so I'm like, I don't know why that would be such a poor outcome and why you have to have that many to make it such a difference. Because in terms of my failure rate, it would take thousands of patients to see a difference between the two because I don't have that many failures anyways.
Yeah.
The point I'm trying to make is that realistically, I go always local. Now, I don't go, some of the techniques say, well, when you punch to put an anchor in, you can draw it locally there. I don't agree with that.
Okay.
2 reasons I don't. One, you're going to then drop, unfortunately, arthroscopy fluid. And that's not good. It'll dilute it.
Okay.
Number 2, it's been shown, and actually this was actually another Hernigu paper, but this one actually I believe, that there's a paucity of stem cells in areas of bony sclerosis. Now that makes complete sense. We've all seen the cystic changes that occur in the tuberosity with chronic cuff tears. So that actually has a lot of validity in my mind. So what I do is I go to the metaphysis, which actually does have a greater number. So I just go lower when I'm gonna get it. Same thing with the tibia. I simply go lower and angle down to get my stem cells.
Got it. You mentioned a little bit about wet versus dry joint. You made the comment that even if it's a wet joint, I'm going to activate it so it'll clot. Do you get rid of the fluid before you do your final injection? Let's say you're going to be subacromial intraarticular. Talk a little bit about that flow.
Yeah, that's absolutely correct. And so we talked about how if you activate it in situ to have it activate where you want it, then absolutely that you want to actually, have either flow on or off, it doesn't matter. But when you're going to put it in, you want it to spread over the entire area, then yes, the scope comes out. I put my needle in place first. I take the scope out. I drain the area, make sure that there's less fluid to dilute the PRP, make sure the PRP is going to go to the whole area to make sure it's going to be able to cover everything. Because I want it to cover everything. Now, the one thing that you want to be careful about is this is the one time that you may consider sometimes taking away the ACD and thrombin.
Okay.
The issue is that if you can actually let it spread out, coat everything, and then activate, it's better. And that's a slower activation. Because if you all activate it, it'll just come out as one clot in one small area. It won't do what you want.
Okay.
So that's definitely, it changes, again, what you're trying to accomplish.
Yeah.
So that's why you have to think about what you want it to do and understanding what it's going to do once you use it.
What do you say to some of the surgeons that may be like, man, that sounds like a lot, right? Like I'm already doing the repair, I'm going through my workflow that feel that they're going to add too much time or it's going to be too complex.
Yeah.
How have you kind of made it, to that it's one step after another?
To be blunt, it's not hard at all.
Okay.
It takes literally 2 seconds to do. So number one, the blood is drawn pre-op, so it doesn't affect me.
Okay.
2, the blood is spun literally as the patient is being brought into the room. It doesn't affect me. 3rd, my techs know how to set things up on the back table, so it's ready to go for me when I'm ready. Doesn't affect me. And lastly, I just simply ask for the syringe, I give the injection, we move on.
Got it.
So it really does not impact at all the surgical workflow. So when someone says, oh, it's too hard, they're being lazy.
Kind of like the use of ultrasound in the clinic.
Yes, and we can clearly talk about that too. Yes, 100%.
Yeah.
Yeah.
I wanted to get your thoughts on intraosseous injections.
Yeah.
So we spoke about injecting directly at the repair site. We talked about subacromial versus intraarticular. What are you trying to accomplish when you do an intraosseous injection?
So this is a really good topic to talk about because this is one of those topics I was referring to in the very beginning where I said having people come up with new ideas and push the envelope forward is fantastic. And this is a perfect example of that. I would have never thought about going intraosseous before, but someone came up with the idea of going intraosseous for these areas that have hyper signal areas on MRI, which are clearly evidence of edema within the bone, which is going to be reactive either from tendinopathy, reactive from cartilage loss and arthritis, but there's clear bone edema. And it turns out, which has been a great, I think, advancement for us, is that these are symptomatic.
Yeah.
And they're also pathologic, which enhance the chances those cartilage lesions will get worse over time. So taking care of these areas of edema, I think, are critical.
Yeah.
And I think we focus too much on the intraarticular space in the past. So now by identifying these areas of edema and then addressing them, I think not only are we going to make the patient feel better, which I know we do, but we're going to enhance the chances that we'll have a diminishment of potential progression of disease down the road intraarticularly. And the reason I say that is the current paradigm of rheumatology is reduction of inflammation in an arthritic joint is critical to helping prevent progression.
Yeah.
That's why PRP is so good. That's why all these different anti-inflammatory medications are good. But if you don't take care of the inflammation in the bone, it's not going to make a big difference.
Yeah.
Because the bone is just as critical to the health of the cartilage as the joint itself. So therefore, I agree 100%. Long answer short, using my ability to place a biologic, and I use DBM and PRP or BMAC, into the bony area of edema, arthroscopically, I can identify where I need to go. Obviously, I don't go through the cartilage, but I have different methods to get to where I want to be, and to be able to do it easily without having to pull out a fluoroscopy. And so, frankly, an arthroscopic method is easy, and I just incorporate it as part of the procedure. And literally, it takes me less than 5 minutes.
And what tool do you like to use for the delivery intraosseous?
So I use the intraosseous bioplasty kit.
Okay.
And so basically, it's just simply you put it on a drill. You basically put a small drill in. You take the cannula out. You attach your syringe, and you inject in your DBM and either PRP or BMAC, and it works easily.
What would you say in terms of the consistency of that mixture, right?
Oh, that's critical.
When how do you, is it something that you look at the imaging and you say, well, I guess there's going to be a 2-part question. One, do you perform a decompression? And then 2, how do you mix it so that it can be the consistency that you want?
Great questions. One, I no longer do a decompression.
Okay.
So meaning I don't use a flip cutter to go in and kind of like ream out the area.
Yeah.
I found that really is not necessary.
Okay.
And this is based on methylene blue studies with DBM where they went in and just putting the drill in, They then injected in, and they found that it actually diffused out really well. So the key, though, is what you said, the proper dilution. Not something I can tell you how to know.
Yeah.
This is experience. And you just have to know what's going to be too thick. And I would argue that if you're going to do this for like the first 2 times, make it thinner than you think you need it. Mm-hmm. That way, then, if it's thinner, you'll have a better chance to have it fill the areas, as opposed to being too thick. Because if it's too thick, it will not spread. Got it. So definitely err on the side of thinner than thicker.
Okay.
Because it's been shown, and I know you do this yourself, and you can tell me if I'm wrong, but don't you inject just simply BMAC or PRP intraosseous alone?
Correct. Yeah.
Well, and you tell me, when you inject it, does it go pretty smoothly through?
It depends, I think, a lot on the age and the bone density of the patient. But in general terms, what I've done to make it simpler is I switched to 1 cc syringes. And what I've done is that I kind of almost, if here's my target, I kind of bypass it a little bit and inject as I come out into the tract I've created.
Same technique I use.
Yeah.
In surgical.
Okay.
It's the exact same.
Same thing.
Yeah, and the thing is that over time you'll get to understand what viscosity you need.
Yeah.
And it is on the thinner side.
Gotcha.
But I do like the DBM for this myself.
Sure.
I think it does help.
Yeah. Just a funny story. One of the first times I used DBM, I clearly didn't know what I was doing in office, and I made it too thick, and I was trying to push so hard.
Oh, yeah.
And it just blew up in my face.
Yeah, you're not the only one that's happened to that. Yeah. I haven't.
So quick warning, make sure you understand what you're trying to do.
Actually, if you're going to use DBM, the key is hold on to the needle, hold on to the syringe, because what will happen is as you push, the syringe will unwind itself off.
Yeah.
So if you keep your hand on both, it'll prevent the unwinding and popping off.
Got it.
That's my secret.
Okay.
So I've actually had that happen, yes.
All right, good. I'm not the only one.
No.
So globally, obviously you've been using this for quite a while. What has been your experience from before when you didn't use it, or still patients that don't do it versus the ones that do it? What are the outcomes? How does that change? Does it change the post-operative outcome at all?
Absolutely. What's interesting is actually what I found post-operatively, patients have a lot less pain faster.
Okay.
And what's really clear, and that's why like the first couple times I did it, I was like, oh, is this really going to make a difference? And I normally have really good outcomes for my meniscectomies anyways, and people get better faster. But of course, we're very aggressive on anti-inflammatory, ice, physical therapy protocols, and we get people rolling. Our main goal is diminish pain as fast as possible.
Yeah.
Even with that protocol, even with people feeling good really fast, where even a lot of my patients don't even take a narcotic post-surgery. In fact, doing this, we were finding, one, they were actually feeling better faster, and they would wake up and go, oh man, that achy pain is just gone. And then secondly, we were finding that the people were staying better longer on average. And so can I quantify that for you? I cannot. Because obviously, in my opinion, and if you look at the different studies, this is validated there. Unfortunately, the outcome is not just related to our technique. It's related to the initial severity of disease that was present. And that's what's going to determine their course over time. And so I think we cannot say, oh yeah, this is going to work for every single person. Because if you have a grade 4 arthritic knee, guess what? It's going to be 50-50 whether this works.
Right.
But if you have a grade 1 or grade 2, this guy's got a great chance to do well for a longer period of time. Because again, the goal is to diminish the inflammatory process to prevent progression.
Got it. Talking a little bit about timing, right? So you're big on PRP or biologics time 0. What are your thoughts on post-op PRP? Yeah. Why don't you do it? Or when is the right time post-operatively to do it?
So it's not that I don't do it.
Okay.
I do, and I will.
Yeah.
But it's what you said. It's not for every person because it's for what reason you're doing it. Got it. So the best thing is, like, I have a patient comes in all the time. They'll go, so doc, should I be coming in like right after surgery to get my PRP shots? And I'm like, no. Why would you want to do that? Well, I want it to heal better. Yeah. That's not going to do that. Because here's the thing. When we're doing it to get healing promoted, we both know that the healing process gets started immediately, within 6 minutes after placing those clots. Because the fibrin clot sets up in 6 minutes in the normal body. Yeah. So the reality is those platelets are activated they're working. The bigger issue is that it seals up.
Yeah.
So the labral repair seals up. It's sealed from the outside area. So giving an injection into the subacromial space would be useless, or into the joints useless. If you're gonna try to get it to heal better, you'd have to go back into the space of healing area, which you're now disrupting, which I don't want to do.
Right.
So the idea of trying to get this into some tiny space non-surgically is like ludicrous.
Yeah.
And it's only going to hurt things potentially.
Okay.
Now, why do I do it? Well, if I have a patient that comes in and like after surgery within 1, 2, 3, 4 weeks, they're having a lot of pain, a lot of swelling. Some people get an inflammatory reaction of adhesive capsulitis. Yeah. Well, guess what? Now it's the perfect time to do it, because this will drop the pain level, drop the inflammation. We'll get them able into rehab a lot easier, get them moving easier. And most importantly, it's not going to hurt the repair. Whereas if you dump a cortisone in there, it's been proven. Cortisone increases the risk of failure of these surgeries. And so by putting cortisone in something, anything under 3 months, you're endangering your repair.
Yeah. Got it.
So that's where PRP is phenomenal. And that's where I'll do it. And what's great is I don't have this protocol like, okay, everyone has to have a PRP after surgery. No, in fact, it's very selective. So realistically, I would say the number of times I'll do PRP in the first week or two after surgery is like literally a handful in my career.
Got it.
Not often.
Okay.
Yeah. And if it's something that they need within the first 2 months, that's a little bit more common because they can get inflamed. Some people don't understand how to keep the inflammation down. So that's when we will do it at that point, that 2 to 3 month mark, potentially.
And I think it's probably very important to state that much like the preparation you're using in surgery, this clearly has to be a leukocyte-poor preparation. Yeah. You know, we can discuss how high you want to bring your platelets, but the reality is you want to make sure it's leukocyte-poor, so that, because the whole point is that you're trying to reduce inflammation, not create more inflammation after the surgery.
But I think there's 2 points.
Okay.
Because I think the first point you make is absolutely perfect, correct, 100%. That having leukocyte-poor is critical because we do not want inflammatory response. Yeah. That's the whole point. You're trying to reduce inflammation because it is inflamed. 2, though, the point about platelets counts, which is in high controversy right now.
Sure.
My issue is that in this situation, I don't care. Because realistically, I'm just trying to acutely get inflammation down. So as long as I can get that inflammation down, it's going to work. Yeah. So do I need that 10 billion platelets? I do not. Yeah. It's not necessary. So getting the platelets to, you know, the standard 2 times, 4 times, that's fine. Yeah. It's going to work. Yeah. Now, would the 10 billion be better? I got to tell you, my experience is no.
Not in a post-surgical patient. Yeah, I think
not for that.
It might actually be detrimental.
Right. Yeah. You know, if you're talking about trying to get some patellar tendinopathy to heal, and it has a larger area, and we did that study looking at, you know, size, cross-sectional size of a lesion on ultrasound, we found that larger lesions didn't heal as well.
Correct.
Okay, more platelets? Yeah, good. More volume? Yeah, good. I agree. I'm not going to argue. Yeah. But in this setting, it does not matter.
It does not matter.
And that's kind of the key point, is that being dogmatic and saying you must always do this or always do this is wrong.
Sure.
And that you have to look at, 1, the pathology you're doing, 2, and you've said this now a dozen times, why are we doing it? Yeah. What's the goal? And 3, what product do you have in your hand? Yeah. And so I will switch up what product I have and change up what I want to do.
Got it. You brought something up. Obviously, these are discussions we've had for many years now, but the point of when PRP clots, right, it's 6 minutes, that reaction has already happened, right? So this thought, you know, you are okay with patients getting non-steroidal anti-inflammatories after PRP. I think we can agree that we don't want them before, right?
Correct.
We don't want to take NSAIDs before PRP to not affect platelets. Yeah. But you are okay with getting NSAIDs almost immediately after, not immediately, but
no, immediately.
Okay, so take us through, because I think, I don't want to say it's controversial, but it's to you, right? But it's something. It's a point of argument, right? Yeah. But I think you your reason, and it's a good one, and it should be heard.
Well, it's also been validated by studies, and it's also been shown that NSAIDs do not really affect the healing process after a surgery. Okay. We give NSAIDs after an ankle sprain.
Yeah.
If it really was hurting and healing, why are you doing that?
Yeah.
Okay, what's the point? So, one, you have to understand the basic science of platelets and healing. So, one, your current point of anti-inflammatories not prior, 100% correct, because it affects bleeding, it affects platelet aggregation, it affects platelet function.
Yeah.
I do not want my function impaired during the surgery, so I want those platelets be able to be activated and used properly. So if you give NSAIDs prior, you're going to hurt your chances of that repair and of that healing to occur if they're on board prior.
Okay.
Now, as we said, if you look at the basic science, how does platelets work? Platelets are activated by fibrin and thrombin and different other mechanisms. Glass, collagen activates platelets. But the reality is, if you look at it, the platelets activate and they form a fibrin clot. All that occurs within 6 minutes. That's why that's the golden rule, because that's what has been proven over time. Therefore, now that the platelets are activated, they have released their cytokines, their alpha granules, and now they're going to do their function. So now the alpha granules are going to work. But if you give someone an anti-inflammatory now and affects your platelets now, it doesn't matter to the platelets that are already activated. It only matters to the platelets that are unactivated, which you don't really care about.
Yeah. They're not in the injection.
They're not there.
Yeah.
So it doesn't really matter. So I think that's the biggest problem I have with the current discussion about NSAIDs.
Sure.
And so frankly, the minute I've done my PRP, the minute I've done my surgery, the minute I'm closing up, and the anesthesiologist asks me, hey, can I give Toradol, which is an anti-inflammatory? Yeah, go for it. Because I'm going to start the patient on an anti-inflammatory protocol the minute they go home.
Okay.
And so they're going to be starting anti-inflammatories that day. Likewise, I do a PRP or a BMAC in my clinic, same protocol. They're going to start the anti-inflammatories that day. Now, if they're going to come back for a second shot next week, we may hold off.
Okay.
But in general, if that's it, if we're done, they can take it.
Okay. One more question. How do you decide between PRP and bone marrow for shoulder surgery?
Yeah, great question. So the key is, in my opinion, is that do you want something that's going to signal stem cells to come, or do you want those signalers and the actual cells themselves there? That's the critical component. Okay. So if you have an area that you're trying to get healed that's very sclerotic, has a poor area that will then summon stem cells, because we talked about that earlier.
Yep.
Or the patient has poor healing potential, has a potentially older person, diabetic, smoker, other medical issues where they're going to have trouble healing, which this may come into play, BMAC for sure.
Okay.
If I have, however, a situation where they're relatively normal, they're just looking for we want to get a better augmentation, better effect, I think just putting the signalers in the right place is good enough.
Okay.
And so really it's person dependent. There is no, you must do this. So you have to kind of assess it based off your thinking of the need for that person. Okay. So if you look at an x-ray and you're going to do a massive cuff repair and you're seeing sclerosis tuberosity, yeah, you better probably pull out some BMAC. Yeah. It's going to definitely help.
Got it. Okay, that makes a lot of sense. Now, in the non-surgical world, we always think of biologics as, PRP, bone marrow, maybe even micronized adipose. In your world, there's also scaffolds, right? Bioactive scaffolds. There's carriers. There's, things like fibrin glue. Yep. How do you incorporate those and how do we navigate through that language?
It's not that tough, to be honest. Okay. Once again, it just comes back to what are you trying to accomplish? What's your goal? So, for example, if I've got a rotator cuff that's severely thinned out, and imagine you're talking about a pair of jeans that you're trying to sew back together.
Okay.
If you have a brand new pair of jeans, the fabric is very thick and robust. But if you've been rubbing your butt on those jeans for 60, 70 years, and now the tissue is like really thin, you put a suture in, it's not going to hold.
Got it.
Well, the rotator cuff is no different. So if you get in there and the rotator cuff tissue is thinned out, well, you have a greater chance of having a mechanical failure of the tissue. Whereas if I'm going in and there's just diabetic that have a great robust tissue, we have a problem of biological healing.
Got it.
And so if I have a problem of biological healing, you're talking about putting in things like cellular biology, PRP, stem cells. But if we're talking about a mechanical failure, we need to augment that with more of a strut patch graft. So that's when we're going to start talking about putting in things like, a dermal allograft or other types of things that will help. Or if I've got like a bony defect, you're not going to fill a bony defect with PRP and expect it to heal back with bone.
Right.
You're going to fill it in with demineralized bone matrix or bone graft. So you're going to talk about a different kind of orthobiologic, because that is an orthobiologic.
Yeah.
So as you said, I classify things as cellular biology, as scaffolds, and then lastly, it's kind of extracellular type of components like exosomes, platelet lysit, which is not a cellular biologic because it's been lysed, so you're not dealing with cells. There's a ton of other ones, right? So to me, there are three main categories. And basically what you're trying to do is, what can your product do? What is the need you have? And then what's the best way you're going to be able to solve that need with whatever product?
Okay.
That's how I decide.
That's how you decide. Okay. So to kind of summarize, I think the ideas here are, with biologics, what are you trying to accomplish, right? And that drives the type, whether it's PRP, bone marrow, scaffold, and that also drives what type, whether it's going to be leukocyte-rich, poor, how you're going to manage your platelet dose. Are you going to activate, right, or not?
Right.
So it's really just about having an idea on what you're actually trying to accomplish.
100%. But I think also it's understanding the product you have in your hand.
Okay.
What is it that you've been given?
Got it.
And what will that product do?
Okay. Where do you see this evolving? Where do you see, let's stick to specifically in surgery, where do you see the field going next?
Yeah, honestly, what I'm hoping that it goes into is acceptance.
Yeah.
Because I think that's what needs to happen, is that the insurances need to step up and understand that this is not black magic. It's not something that's fairy dust. It's something that we're trying to help our patients. And I think that's the number one place it needs to start.
Got it.
If we can start there and give doctors the ability to start using this more, we're going to have a better chance to advance our knowledge and advance our ability to take care of people. Right now, because the US is being so difficult to allow physicians to use this technology, we're missing an opportunity in research.
Yeah.
And unfortunately, the US is so US-centric in terms of not believing other countries' data and other countries' outcomes, that now we're going to lose out because these other countries are doing these things. They're using them. They're experimenting. They're doing the research. They're going to get the proper answers.
Yeah.
The question is, will the US believe that data? Because if they're not, how are we ever going to get there?
Get there, yeah. Understood. Well, thank you. We're going to close. I got some fun but insightful questions to finish here. So if you were stranded on a desert island, what surgical tool would you want to make sure you have with you?
Well, if I'm with you, I'd want a scalpel to be able to make sure I have enough meat to survive.
Got it. Fair enough.
If I'm by myself, a tourniquet, so if I get hurt, I'll be able to not die.
There you go. Nice. All right. Coffee or matcha? How many cups are we taking before first incision?
Matcha, 0.
0. I'm also not a big fan. I don't know. People love matcha, but
It's because you've had bad matcha.
Yeah.
If you had good matcha, you'd understand.
What about mate? Have you drank some mate?
Mate is phenomenal.
Yeah.
Yeah, but it makes me completely wired.
I know.
Yeah.
I'm from Argentina, so we drank it quite a bit. I hadn't drank it in years, and I made the mistake of I was in the Gobi Desert and I drank it right before bedtime, and I was just not a good idea.
Yeah,
exactly.
I did that too. I was in Trilu in Argentina visiting the penguins, and I had my first encounter with matcha at a card game at dinner, and yeah, that was it for me. I was up all night.
All night.
Yeah, terrible.
2 more. So if you could fast forward to one innovation in shoulder surgery, what would you want to see?
In the future,
Yeah.
well, we're kind of going there already. For example, one, we're seeing smaller and smaller cameras, which I think is really critical. We're seeing advancement already in the ability to see better, see wider, see into areas we could never see before. The innovations we're seeing in that has been amazing. Secondly, what I'm seeing currently today, and we're still not there, but we're getting there, is that the innovation of diminishing the size of our anchors and our ability to fixate tissue better and better over time. This is going to really help us because we need bone to be able to get things to heal. If we put an anchor that's massive in place, we then take up bone area that we would have wanted for healing. So by getting smaller fixation points, which we're doing, because we're now down to 1.8 millimeter anchors, we are doing better and better about getting that chance that it's going to heal.
Got it. And we'll close with, you've been a very influential mentor for me. Who has been an influential mentor for you, and what's the best advice they gave you?
I would say Tony Miniacci. I mean, he was my fellowship director, and he's definitely the best surgeon I've ever seen do surgery. His hands are the best that I've seen in the world, and I've been all over the world and met a lot of people, and not to downplay anyone else.
Sure, that's not what it's about.
Not at all. It's just that the guy is incredible. I remember my first day of fellowship, and I remember walking in and doing surgery with him the first day. And I walked out, and I walked to my office, and I just put my head between my legs going, what the hell? He walked in, he goes, what's wrong with you? I go, I've done the most scopes of anyone in my entire residency. I've read most of the books available. Yeah. And I don't know shit. And he laughed at me and he goes, well, guess what? That's why you're here. And you don't need to go read anything else because you definitely know enough. You just need to be taught the proper methods. And that's kind of the key point. And that's why we're here, and that's why we go do these things, is to help people get ahead, to help them understand that they're not inadequate. They just need some education and some guidance about the proper way to go, and they'll get there.
Got it. Well, thank you so much.
Thank you for having me.
Absolutely. Don't forget to like and subscribe to our channel if you like more of this content. Again, very grateful for Dr. Alan Hirahara to be here with us. If you scroll down, there'll be links to a lot of the papers that we refer to, as well as some of our previous content. So thanks again, and see you guys next time.